Alright, so these are going to be the last 30 questions of NBME 22. I finally finished writing out all the explanations. So just give me a second. Let me let everybody know on the Facebook page. Again, NBME 22 was really good. I really liked the way the questions were worded. I really liked the answer choices they used. The questions were not completely bullshit. There were a few, very, very few though, compared to how many they usually have. There were very few questions that were extremely bullshit. But they didn't really have any really bad mistakes. Oftentimes there are questions that seem like they don't quite fit the truth, I guess. And little technical errors that they do make once in a while. I've seen that a lot. But other than that, it was a really good NBME. I feel like it was perfect for studying. It was perfect for figuring out how ready you are for step one. NBME 22 also does a really good job by testing you on topics that you might have either taken for granted or really not understood perfectly. And then on top of that, it was also full of questions that were slightly easy too. So it was nice. It was a good NBME, especially for those who took it, when they needed to for their school. Hopefully they did well. So this is where we left off last. This question says, which of the following drug effects is the most common reason for non-compliance with cyclic antidepressant therapy? All right, so let me also move my first aid here. Okay, so anyway, here, so why do people often end up not complying with the TCAs that they're prescribed, right? So TCAs are antidepressants, tricyclic antidepressants, and they don't take it because of the anticholinergic side effects. So you have to remember the 3 C's of TCAs, right? Tricyclic antidepressants. The 3 C's are CNS, cardiovascular, and cholinergic. These are all blocked, right? Because antidepressant. All of them are blocked. This little summary over here does a better job telling you everything that TCAs kind of do. And then if you look in the book, so 623, let's take a look. They're discussed over here as a list of all the medications. So they have some different names. There's the triptylines, there's the imipramine and other pramines, and then doxepin and amoxapine. 3 different sets of names basically, and any of these can show up on your test, and you would have to remember their TCAs. So here they tell you the 3 C's are convulsions, coma, and cardiotoxicity. You get arrhythmia due to a sodium channel inhibition. You have to treat it with sodium bicarbonate, right? And this is discussed even more. Where was it? What page? 616. All right, so let's take a look at that earlier page. Even more here under psychiatric emergencies, right? So they have the TCA antidepressant toxicity, which obviously someone who is depressed might actually try to use for committing suicide. So when you have a TCA overdose, you get respiratory depression, hyperpyrexia, prolonged QT, and then to save them, you do supportive treatment, monitor the ECG, give sodium bicarbonate. And how does that work? So sodium bicarbonate, right here, they explain in another UWorld question that it increases the serum pH and extracellular sodium, allowing you to kind of undo what the TCA was doing to the person. And then, of course, you could use activated charcoal to kind of help remove any pills as best as possible. Right? But other than that, you should definitely know all the different symptoms that come up from taking TCAs. And then it's also pretty important to understand where you would prescribe a patient a TCA, right? So go back to 623, because it's not really a medication you give to someone very commonly. So here, they tell you clinical use, major depressive disorder, peripheral neuropathy, chronic pain is definitely one place you could use it. Migraine prophylaxis, again, not really. You wouldn't necessarily give this for migraine prophylaxis because it's not really a very safe medication to take. There are many other options to give for migraine prophylaxis. Clomipramine is used for OCD. That's definitely been seen. And then we also discussed imipramine for nocturnal enuresis, but we try not to use imipramine, and it's actually more preferred to use desmopressin for nocturnal enuresis, and before you even give medications, period, to treat kids who have nocturnal enuresis, you try to use motivational therapy to get them to quit, right? Like a star chart or anything. So a lot to know about this medication. Very, very important to know everything about it, because it's definitely one that you can get tested on very easily. Right? So people stop taking it because of the anticholinergic side effects. 65-year-old man comes to the physician for a follow-up exam. He has a 15-year history of poorly controlled type 2 diabetes, resulting in multiple peripheral neuropathies. Neurologic exam shows wasting of the interosseous muscles of the left hand and inability to abduct the fingers of this hand. Plantar flexion of the right foot is absent also. The function of which of the following pairs of nerves is most likely impaired in this patient? Right. So they have two different completely unrelated things. There's the hand, and then there's something in the leg. Both of them are being affected in this patient. No, thank you, Iman. I really appreciate that. That's always nice to see when people are very supportive of stuff like that. Thank you. I really appreciate it. Thank you. So this question is kind of just really getting you to break down, what nerves would be related to the symptoms this patient has. So you have the interosseous muscles, and then you have the plantar flexion. And these are really easy things to remember. NBME does like testing you on anatomy-related topics. And oftentimes the anatomy is pretty ridiculous, but here the anatomy wasn't so bad. So the first thing, your hand muscles, right? So let's take a look at that, page 481. Look at the hand muscles. So right here they tell you your interosseous muscles, both the dorsal and palmar, they're all ulnar. Right? So ulnar nerve would be responsible for the interosseous muscles that he has difficulty with. So immediately you're just down to E and F, right? And then you have to remember what helps you do plantar flexion. Another way you could take this question would be to first remember what helps you do plantar flexion. That's actually easier to remember, because when you look at the legs, so let's go to page 491. That's another 10 page later. You look at the lower limb. So here you can see you have your common peroneal and tibial. And when you were studying these two nerves, you did look at the fact that PED helps you remember peroneal everts and dorsiflexus. If injured, you would have foot drop. And TIP for tibial inverts and plantar flexus. If injured, you cannot stand on your tiptoes, right? So this would be a very simple way for you to remember the plantar flexion. And once you catch that, if you remember the plantar flexion, then you're just down to B, D, or F. And now you have all three of your hand nerves, and you would have to remember which ones are responsible for your interosseous. So ulnar nerve is the one that's responsible for both sets of interosseous muscles. And then always remember the tip and pet stuff. That's pretty important. Okay, let's see, what is this? So that's 171. All right, 172. So a 72-year-old man is given ketorolac for pain control after an abdominal operation. He has a 20-year history of hypertension and type 2 diabetes. He's at greatest risk for which of the following drug-induced adverse effects? And then you look at your answer choices, and acute renal failure might not look so appealing to you, because the question didn't have any mention of anything about the kidneys at all. And then you see addiction to pain medication, and you're like, oh yeah, abdominal operation. You most likely don't remember what ketorolac is, and then you're like, it's probably some kind of opioid, and you pick B and you move on, because C, D, and E really don't make any sense. But ketorolac is actually an NSAID. Right? It's one that almost no one ever mentions. Ketorolac is not an opioid, it's an NSAID, as well as diclofenac, meloxicam, piroxicam. These are other opioids very few people actually, see in questions. NSAIDs reduce prostaglandin synthesis, and prostaglandins dilate the afferent renal artery. With reduced blood flow to the kidneys and thus reduced GFR, the patient is at risk of pre-renal azotemia, which can lead to acute renal failure. Right? And he's 72, so his kidneys aren't exactly doing as great as they used to do a couple years ago. This was a little interesting. I wouldn't classify this question as complete bullshit, but it was something that most students wouldn't necessarily know all that well. So a 62-year-old man is being evaluated for rectal bleeding, An X-ray of the GIT with contrast material is shown. Which of the following is the most likely explanation for the feathery appearance in the portion of the GIT indicated by X when compared with the portion indicated by Y, which is, very, very bright? So now this is obviously a question about GIT anatomy, and it's really important to realize that, things done on the left and things on the right, what are they, what part of the GIT we're looking at, what's special about those parts of the GIT, that's also significant, and then try to compare your answer choices. So evidently, the portions marked by X, as you can compare with this picture I put here, are definitely part of the small intestine, right? Its characteristic feathery appearance after a barium meal is due to permanent circular folds and villi. The villi give the small intestine a greater mucosal surface area, and there's more absorption happening. The reason you can't see so much barium edema there is because it's been absorbed, right? That's the most straightforward way to kind of look at it. Mucosal folds are largest and most numerous in the jejunum and tend to disappear once you get to the lower ileum. Y might be the beginning part of the large intestine, right? So after you get to the terminal ileum area and whatnot, then you go into the intestine. That's kind of what we're looking at right here. Much less absorption is happening, and then you've started entering the large intestine, right? So when you look at all your answer choices, absence of circular muscle, fewer villi, like these muscle exactly isn't going to be what, figures out how much of the barium you're going to be able to see. So muscle wouldn't make much sense. Fewer villi would mean that there's lesser absorption, right? Lesser absorptive area, and all the barium is just going to be in the lumen, which is what you're seeing in the much brighter areas. Greater bowel motility. Again, motility wouldn't just be greater in, midsections, right? Motility would be greater in either the whole thing or, a really, really big portion of it, but this is just intermittent sections where it's kind of just, grayed out. You don't really necessarily have significantly greater bowel motility in such a way that it'll affect your barium visualization. And then the last one, lesser circular and longitudinal muscle. Again, the amount of muscle that's there doesn't really have an effect on how much barium you're going to see. So greater mucosal surface area was the only answer choice that made sense. It was the opposite of answer choice B, right? The opposite of answer choice B, and it's because you have more absorptive space. You kind of distribute the barium into more crevices in a sense, okay? And then it becomes all feathery looking. So that's really all that one was. This one definitely caught a couple people off guard. So a 35-year-old man comes to the physician because of a 3-year history of an enlarging nose, coarsening of his facial features, muscle weakness, and increased hand and foot size. Physical exam shows a large fleshy nose and prognathism. Serum studies show an increased insulin-like growth factor 1 concentration. An MRI of the brain shows a pituitary adenoma, right? So there's definitely a pituitary adenoma that's causing him to release more growth hormone, basically. Morphologic analysis of the biopsy specimen of the tumor shows a densely granulated somatotroph adenoma. Further studies show that the G-alpha S subunit of G proteins in the tumor lack GTPase activity, right? And that's clearly a very significant part. This part might not mean shit to you, or it makes all the sense in the world to you, but it's definitely a very important part of the question. The tumor cells in this patient most likely have an increased activity of which of the following enzymes? Right, so the tumor cells lack the alpha subunit of GS proteins, right? And that's why they don't have enough GTPase. What does that mean, right? So here, then you look at answer choices: adenylyl cyclase, guanylyl cyclase, Janus kinase, phospholipase C, tyrosine kinase. So when I saw the GS part, right, and they're asking you that he's going to have increased activity or something, GS is almost always related to adenylyl cyclase, so I really was pretty sure it's just going to be A. And it was pretty easy to just pick that and move on. Growth hormone releasing hormone. And a lot of people were confused this is going to be actually growth hormone, but it wasn't. Growth hormone releasing hormone acts via G-coupled receptors. G-coupled receptors need GTP to become activated and GTPase to become inactivated. Without GTPase, the chronically active growth hormone releasing hormone receptor will have constant activation of adenylyl cyclase and cyclic AMP pathways and the release of growth hormone. Right, so, online I saw someone said something like, why is the answer adenylyl cyclase? I looked in FA and I saw that growth hormone uses the JAK2 STAT pathway and the IGF-1 uses MAP kinase pathway. Not sure how adenylyl cyclase plays into this, right? That's something that someone was confused about. And, it's a totally understandable confusion to have that. The first thing I would say, though, is if you see, it's an understandable confusion, but the question is really just about growth hormone releasing hormone receptors on somatotropes, which really work through cyclic AMP. The question explicitly tells you there is an issue with the alpha subunit of GS, and GS works with adenylyl cyclase. That was the real giveaway. If they weren't talking about the alpha subunit of GS, then you could, deduce more things, and the question would be pretty incomplete at that point. So if we go to this very critical page that you need to spend at least an entire day to kind of master, you kind of see it. So signaling pathways of endocrine hormones. I have a bunch of notes here. We've talked about this stuff already when I did the videos for endocrine. This is in the last video of endocrine physio right before endocrine path. And it takes some time, and you're supposed to memorize each one like one at a time. So just memorize all of these. And then once you have that down, cyclic GMP is the easiest one to remember as bad grandpa. Intracellular receptors are really easy to remember too. They're all cholesterol derivatives as well as glucocorticoids. Right? Corticosteroids are also sort of cholesterol derivative types. And then of course steroids. You always think of testosterone. Then the slightly harder ones to remember are definitely IP3 is the hardest one to remember because the hormones in here are very random. Oxytocin, angiotensin 2. You have a releasing hormone here as well, although most releasing hormones were up here. And then receptor tyrosine kinase and non-receptor tyrosine kinase. So you have to spend a lot of time getting these two guys down as well. It takes time. It definitely takes time, but you can do it. Now, if you were thinking of growth hormone and IGF-1, notice that these are all, you couldn't have a question on both of them because they both use completely different receptors, right? IGF-1 is a growth factor. Growth requires a map, right? To grow your country, to grow your nation, you need a map. And of course, insulin is also anabolic, which makes you grow. So there's many ways to think about it, but in general, growth requires a map, and MAP kinase was not one of the answer choices. And then, of course, if you thought growth hormone was the answer, then yes, you could pick the Janus kinase one. Right? You could pick C as an answer choice and move on, but our question was really about this image. And you can see the adenylyl cyclase here. The alpha subunit of GS is right here. It uses the growth hormone receptor, right? Growth hormone releasing hormone receptor, excuse me. Now, this is again something that you would never have seen. You probably never saw this picture before. You wouldn't really necessarily know this stuff. The only way for a normal student, and by normal meaning someone that doesn't know everything, for a normal student to actually get this question right, you would have to bank off of the GS part and just pick adenylyl cyclase, and you'd be done. This one was also a little hard. I got this question wrong because I hadn't really seen anything like this before. So a 52-year-old man comes. This was the 7th question I got wrong on this NBME. So a 52-year-old man comes to the physician because a lump in his inguinal region, which had been present for 4 months, has recently enlarged and became painful. It is determined that a direct inguinal hernia is present, and a segment of gut has pushed through the superficial inguinal ring. Which of the following will be impaired if the herniated gut compresses the nerve that lies on the external surface of the spermatic cord at the superficial inguinal ring? And, when you see this, you close your eyes and you try to think about, when you ever heard of anything like this on that page, and you didn't. They didn't mention anything like this on that page. None of this is actually discussed on that page. In musculoskeletal toe, you do discuss some of these nerves, right? The iliohypogastric, the ilioinguinal, genitofemoral. You do discuss these nerves. You don't necessarily see how they travel, but you do see the plexus they come off of, and that's really all you get there. Right, so here in this picture, they've kind of color-coded its distribution and breakdown and where it kind of provides sensory innervation, so you get to get an idea of that. And here the answer was C, sensation from the anterior surface of the scrotum. Oh, my cat's going crazy. Sensation from the anterior surface of the scrotum. So that's going to be your genitofemoral nerve, which travels like this right here. Right, that's the blue area. Okay, so that blue area is the one that's being hit, and this is the anatomy they're talking about. Right, traveling along. Where do they say it? compresses the nerve that on the external surface of the spermatic cord at the superficial inguinal ring. Right, so they're talking about the genitofemoral, right? And it's a very weird question. I don't see how someone would remember this. I mean, I can see someone guessing it correctly, but even then, the answer choices aren't nerves. It's like you have to remember what the nerve did too. Right, so it was just answer choice. This was a pretty hard question, but you get to learn. You get to see this stuff, and you get to understand something new, I guess. This was easy. So Clostridium perfringens alpha toxin affects cells and facilitates the spread of gas gangrene by which of the following mechanisms? This is the sketchy microimage showing you the alpha here as a note that's just being hung. And these clips that are used as hangers, they look like the bilipid membrane, right? You can see they actually look like a lipid, lipid bilayer membrane thing. So that's actually how alpha lecithin works. Actually, this enzyme is called alpha lecithinase, right? Alpha lecithinase. It cleaves lecithin. That's exactly what it does. And by cleaving that membrane, it opens it up and allows gas gangrene to actually occur. And you hear that as like weird crepitus. So the sketchy microimage did a really good job talking about that. Because of this alpha lecithinase enzyme, you actually get a double zone of hemolysis. So if we take a look at that real quick in the book, the double zone of hemolysis kind of looks like this image here. So you can see how there's an inner zone and an outer zone, right? The double zone of hemolysis, and this is the crepitus stuff, the gas gangrene stuff that happens, right? Soft tissue crepitus and hemolysis. So very important to make sure you know how this works. But other than that, this question was pretty straightforward. This was NBME's attempt of intimidating you again. So they do this quite often. They'll pick an image of something you've definitely seen and present it to you in a very weird way, right? But you've definitely seen this before. This is this picture, except this time they're using a stain that kind of makes all of this very black, right? So they're staining it in a very unique way here. So a 63-year-old man a 63-year-old man has had progressive stiffness over the past 2 years and now has difficulty initiating movements. He has a tremor of his head and hands that is worse when he sits quietly. Which of the following labeled structures in the photograph undergoes degeneration in this condition? Excuse me. So you can tell from the description of the patient that they're giving you in this question that this is a Parkinson question. And when you look at this, you can definitely at least identify the lateral ventricles, right? Once you identify the lateral ventricles, you should be able to figure out what everything under it is, right? So I labeled everything. A is pointing at the hypothalamus, B is pointing at the putamen, right? And C is pointing at the subthalamic nucleus right here, right? So subthalamic nucleus under the hypothalamus. And D was our answer. D is the substantia nigra, which is the lowest and most medial thing, right? That's the one right there. This is another picture showing you something that pretty much looks exactly like that because it's the same stain again, and it's got everything labeled, right? So you see your substantia nigra is this one right here, very medial, very low. Okay, and then above that, as you keep going, you get your subthalamic nucleus, right? Right on top of this white area, you have a darker subthalamic nucleus, and then above that here, you have your the hypothalamus and thalamic stuff, right? So very important to be actually able to break this diagram down. This is actually in the book too. So we look at it real quick. 542. Right here, they kind of show you all of that, right? So you have your thalamus, hypothalamus. Oh, sorry, excuse me. Did I label? I did. My bad. A is the actual thalamus, right? It's big. It's really big. That's the thalamus. Under it would be the hypothalamus, which is why it's called hypothalamus, right? So remember, your hypothalamus is like dead in the center. It's the green thing here, right? The big ones here, that was your thalamus. So I fixed it right now. But the hypothalamus is like right in the middle, on the it's crossing the midline basically like that. And on both sides of that, on both sides of the hypothalamus, you have your subthalamic nucleus, right? Subthalamic and hypothalamus, those both mean under the thalamus. So if you remember where the thalamus is, you know the things directly under it are either subthalamic nucleus or the hypothalamus. Under that even, the lowest thing is your substantia nigra, okay, which is also, again, sub, right? So sub kind of means like under. Not so hard to remember, you know. And then on the lateral sides, you have the red and blue stuff. Those are just your lentiform nucleus, and you know, on the top up here, you have your caudate. And so definitely want to make sure you get this stuff down very well. You know, thalamus, putamen, yeah. So don't ignore this stuff, because it's like an easy anatomy question. It's a free point you don't want to lose. Here they did a really good job describing a patient who clearly has Sjogren syndrome. So 40-year-old woman comes to the physician because of a 6-month history of dryness of her mouth and itching and burning of her eyes, because those are also dry. Physical exam shows inflammation of both corneas and sclerae, enlarged salivary gland, and a paucity of saliva. She's dry everywhere. Serum anti-nuclear antibody assay is positive. She's also told that she's at the risk of developing a lymphoma. Which of the following is the most likely mode of inheritance, right? So they could have made this question a little harder by then asking you what kind of lymphoma is she at a risk of. So you should definitely check that. But this is an autoimmune disorder, and generally speaking, most autoimmune disorders, especially those that are discussed under the musculoskeletal section, are all inherited due to multiple factors. None of them are defined by a specific genetic mode, like autosomal recessive or autosomal dominant. Her dryness was a giveaway for Sjogren, and you note anti-nuclear antibodies as well as rheumatoid factor, SSA and SSB, which are the Rho and La, right? SSA and SSB are both anti-ribonucleoprotein antibodies. Those are also something you see in Sjogren. So if we go to 514, just take a quick look at what they're talking about. This is the Sjogren, right? And the lymphoma they're at risk of is malt lymphoma, mucosa-associated lymphoid tissue lymphoma. I definitely need to make sure you remember that too. Malt lymphoma is mostly discussed in GIT, and then in an earlier question in the same NBME, we saw malt lymphoma is actually discussed again in hem-onc as well. When you look at all your lymphomas, let's take a look at, where is it? Yeah, right here, when you look at marginal zone lymphoma is associated with chronic gastritis, which can lead to malt lymphoma. Right, so malt lymphoma, and again, Sjogren syndrome too is right here. So marginal zone lymphoma can be an answer choice to a question where they're talking about, talking about a patient just like ours, and then instead of putting malt lymphoma, they'll just put marginal zone lymphoma as an answer choice. So if you ever thought marginal zone lymphoma was one of the least high yield ones on this list, you were wrong. It's pretty high yield because it's related to very high yield topics, Sjogren and chronic gastritis. Of the two, chronic gastritis is a huge high yield topic, so you definitely want to make sure you know marginal zone lymphoma very well. And there isn't too much to know about it. I mean, the translocation is a little hard to remember because I can't really fit it into the name like I did with the others, mantle cell, Burkitt lymphoma. But, it's like you remember 1118 because you remember the others, right? The others all have numbers that you can kind of easily memorize. So if you have a list of answer choices that are translocations, you should be able to identify 1114, 814 with these two, and a couple others with others like 922 and whatnot. And it'll probably leave you with 1118 to pick, and 1118 is marginal zone lymphoma. Okay, here, 18-month-old boy is admitted to the hospital because of generalized tonic-clonic seizures, history of mild developmental delay, no family history of seizure disorder or major medical illness. He's at the 25th percentile for length and weight and head circumference, which is all significant. Earlier, I talked about the exact significance of such a sentence, right? The percentiles. This kind of stuff is only significant if they give you percentages that are 40th or below. If someone is in the 50th percentile, 60th percentile, that doesn't mean that there's something clinically relevant that's problematic. But if they give you lower percentages like this, under 40, under 30, that makes it more significant. Physical exam shows 6 hypopigmented macules scattered on the torso and wrist, flesh-colored lesions on the back. An MRI of the brain shows multiple lesions in the cerebral cortex. Which of the following is the most likely diagnosis, right? So they're talking about neurocutaneous disorders. However, when you see hypopigmented macules, flesh-colored lesions on the skin, right, and then the patient is presenting with developmental delay and seizures, all of that summarizes tuberous sclerosis. It's actually not so bad to memorize all those neurocutaneous disorders and understand how they're different from each other. Let's just take a quick look at them. So our question is about tuberous sclerosis, which is pretty high yield in NBME and definitely high yield in step 1 too. All neurocutaneous disorders on this page are autosomal dominant except for Sturge-Weber. Right? Sturge-Weber is non-hereditary. Right? It's just a neurocrestal derivative issue, which by itself makes that a high yield topic. But tuberous sclerosis is inherited autosomal dominantly, TSC1 mutation on chromosome 9 or TSC2 mutation on chromosome 16. And those are our tumor suppressor genes. So if the tumor suppressor is not working, you end up having higher chances of getting weird cancers. In the book, they tell you, right, you're going to get hamartomas, angiofibromas, mitral regurgitation. Ash leaf spots were kind of what they were describing right now. So ash leaf spots, you would think of like this thing, right? And then C, D, and E. Yeah, C, D, and E. Right. They didn't give you the rhabdomyoma stuff in our question, but then they also did go on to describe the Sjogren patches, which look like this. Sjogren patches are flesh-colored patches like this, usually on the back. Right, leathery texture hamartoma of connective tissue. Another question on, I believe, both UWorld and another NBME question asked, about what other things you could see, and there's this little snippet right here. Right, in tuberous sclerosis patients, you can see subepidermal giant cell astrocytomas, which are like that, or ungual fibromas, right, ungual end finger, right, like that, under the nail. So there's a lot of things that happen in this, and you have to make sure you know it. Now, the only other one that really has a lot of cutaneous things is actually NF1. Right, you have your café au lait spots, you have your cutaneous neurofibromas, and the cutaneous neurofibromas are kind of what make it a giveaway. If they don't give you the cutaneous neurofibromas, then you will have a little more difficulty figuring it out unless they, describe pheochromocytomas to you. Because neurofibromatosis type 1 is really just identified by the cutaneous neurofibromas and the pheochromocytomas. Right? The other things here are not exactly giveaways for NF1. And that's really it. There's really not much else to kind of master on this page. VHL is a whole different thing, and there have been many questions on VHL as well. You have to remember that this actually ubiquitinase hypoxia inducible factor 1A, right? And if you have a deletion of VHL, then you kind of can't do that, right? And you end up getting all kinds of weird cancers, but not so much in terms of cutaneous stuff. Sturge-Weber is really easy to memorize just because of the whole tram-track aspect of things with the cranial nerve V1, V2 distribution. But there are some skin-related things in that one as well. And that's, those were most of the answer choices here. Incontinentia pigmenti was actually the correct answer. So here is just an answer choice, but that was actually the correct answer in another question on another NBME. So incontinentia pigmenti, I have a link right here to describe it to you. You basically just see hyperpigmentation and a couple other issues in some patients. So you could definitely take a quick read at it to know what that is. But as I said, like when you do a question and you see an answer choice that you've never heard of, you should definitely make sure you look it up because it could be the correct answer on the next question you do. Here, a 62-year-old woman comes to the physician 3 days after discovering a painless mass in her left breast during self-exam. She has not had any weight loss or other recent symptoms. Mammography, 18 months ago showed no abnormalities. Menopause occurred at the age of 50 years. She takes no medications, no family history of breast cancer. Physical exam shows a 2 centimeter. So this part is important now. Physical exam shows a 2 centimeter firm, non-tender mass in the upper outer quadrant of the left breast. There is no axillary lymphadenopathy or nipple discharge. Mammography shows an extremely radiodense mass with irregular margins. It contains clustered, irregular microcalcifications. And that's also very important. Which of the following is the most likely diagnosis? Okay, so breast cancer questions can be very difficult if you haven't really had much practice with them. But, as usual, the things you care about are the age, the actual physical exam, and then anything else you saw in terms of mammography. So they gave you all of that, right? And then you can go ahead and look at all your possible answer choices. And and cancel out answer choices based off of what you know. So most common in premenopausal women are fibrocystic changes, intraductal papilloma, and fibroadenoma. So if you see any of those as your answer choices, you knock them out. So that immediately actually knocks out C, D, and E. On top of that, if you didn't remember, what's most likely in premenopausal women versus postmenopausal women, if you didn't remember that, it seems most likely though that whatever she has is an actual cancer of the breast. For one thing, she's old enough to get a breast cancer, right? Women eventually, and very commonly, women eventually do end up having breast cancer. And her being 62, it's most likely that she has breast cancer. On top of that, not only does her age kind of give it away, this mass is 2 centimeters and it has a bunch of microcalcifications, right? Irregular margins. It's all kind of giving away a sign that this is most likely a breast cancer. And answer choice A is a breast abscess, which, doesn't really, it's coming out of nowhere. It doesn't really make sense. So you could just pick carcinoma of the breast and move on and you would get it right. But it's always nice to do a little more and figure out what kind of cancer she could have based off of what they gave. So more likely in postmenopausal women are one of these many other things. You could have a phyllodes tumor, which is a fibroadenoma-like tumor. This thing has leaf-like lobulations in histology and polylobulated masses on mammo. They didn't give you that, okay? And you could also just be breast cancer, right? Breast cancer increased risk due to increased age, duration of estrogen throughout the life, like when she started menarche, how late she ended menopause, whether she has obesity, atypical hyperplasia, or first-degree relatives, but she doesn't necessarily have any of that in this question. They didn't really give us that, right? So we can't just, of course, if they had other answer choices, it would be better, but we can't really figure out what kind of breast cancer she would have yet. Then you move on, right? Question presents with a 2 centimeter firm, non-tender mass, no axillary lymphadenopathy or nipple discharge, extremely radiodense mass with calcifications. So what can it be? Can it be ductal carcinoma in situ? Well, ductal carcinoma in situ does not produce a mass. It usually arises from atypia, right? Hence the in situ part. In situ part should remind you that it's not going to be a mass. It's actually something that's happening on the cellular level. So ductal carcinoma in situ would not be the answer. Could it be a comedo type of ductal carcinoma? Not really, because, again, this thing also does not have any mass, right? Paget disease. Well, Paget disease of the breast has an eczematous skin of the nipple, right? So, again, they didn't give you anything like that in this question. No axillary lymphadenopathy, no nipple discharge. So you can't say it's Paget disease of the breast either. Invasive ductal. Okay, now this one was the type that she kind of had. So invasive ductal forms duct-like structures, mass is detected by physical exam, which she has, usually 1 centimeter or greater, which she has. Connective tissue growing with tumor supports the tumor. Again, she has that too, which is why she has the irregular margins. And that would be what you would pick, invasive ductal carcinoma, right? But they didn't make you pick between one answer choice over another. But on step 1, that is what you would get. On step 1, you would get a patient who has breast cancer, and the answer choice isn't just going to be breast cancer. It's going to be which kind of breast cancer, right? And when you go to first aid to kind of study that, you want to make sure that you make your own little diagram to break it all down, right? These are the benign breast diseases, right? All of these fibrocystic changes, inflammatory processes, benign tumors like a fibroadenoma, intraductal papilloma, phyllodes tumor. These are all very benign, right? And again, you can see how they're going to kind of present, and you do need to know if it's radiodense, radio-opaque, etc., etc. Very important to understand that. But again, our patient didn't have any of this. Then you go to breast cancer, and of course you need to know all the genetics of it. That's very important. You also need to understand the lymphedema stuff with the orange peel appearance. That's another thing that's very high yield. And then you start looking at it. Can it be, and as soon as it goes to, breaking down all the breast cancers, it's either going to be non-invasive or invasive. And you can see the non-invasive ones, ductal carcinoma in situ, Paget disease, lobular carcinoma in situ. These are all in situ. In situ means that it came on the cellular level, so there's no mass, right? There's no mass. Even lobular one, it's not even something you can find that easily. It's incidental biopsy finding, okay? Paget disease, this one has this weird thing that happens on the nipple, right? Very messed up, eczematous patches over the nipple and areolar skin. So, very easy to understand these 3 guys. Very easy to understand these 3 guys. Then you have the invasive carcinomas, right? Invasive ductal, invasive lobular, medullary, and inflammatory. These are the ones you have to spend a little more time understanding. And there was an errata here. They made a mistake. They made it look like when they put subtypes here that they were talking about subtypes of invasive ductal. But these subtypes are kind of about everyone. All of these have these subtypes, tubular or mucinous, right? So don't get that messed up. But these guys are all very different from each other. There's a lot to know about them. And invasive ductal is the one that's a firm, fibrous, rock-hard mass with sharp glandular margins and desmoplastic stroma, which is kind of everything they gave to us. And that's basically what you go with. Painless, can have microcalcifications. All right, my notes: star-shaped lesions due to microcalcifications of tissue, very painless. This is something that's not in first aid itself, but this is something I found from another UWorld question about the same thing as well. All right, so don't overlook anything on this page, because it's very easy to get these things right. So let's not mess that up. It's really just a memorization type question. Excuse me. Okay, here, 65-year-old man comes to the emergency department because of a one-day history of shortness of breath. He has hypertension and type 2 diabetes, no history of heart disease. Current medications include hydrochlorothiazide, ramipril, and metformin. He doesn't smoke. His temperature is 98.6, pulse is 110. Respirations are 28 per minute, and blood pressure is 152/92. Pulse oximetry on room air shows an oxygen saturation of 90%. Cardiac exam shows an S3. A grade 2 out of 6 systolic murmur is heard over the lower left sternal border, radiating to the axilla. The point of maximal impulse is diffuse and most prominent in the axillary line. Which of the following is most likely on pulmonary auscultation? Right? And they love doing this to you on questions of this type. All they wanted to know is what's most likely on pulmonary auscultation, but they gave you a lot of shit in the question, so that by the time you arrive at the answer choices, you kind of, you don't even know what you were supposed to pick on. This is where, people who practice questions by reading the last thing first, what's most likely on pulmonary auscultation, and then reading the rest of the question, this is kind of where it helps. It does help a lot. But, at the same time, as soon as if you were reading attentively, and I was, then you can definitely tell that this patient has heart failure type symptoms, right? The blood pressure is very high. It doesn't look like he's being able to manage it very well. And then you have cardiac exam that showed you a lot of symptoms that look like the heart's not doing that well. And he doesn't really have a pulmonary symptom. He doesn't really have necessarily COPD or anything like that, right? He doesn't have a pulmonary pathology, is what I meant to say. So since he doesn't have a pulmonary pathology, we're not really going to pick one of these other answer choices like egophony, wheezing, whispered paterlique, unilateral decreased breath sounds. Those are all actually very specific to something else. This guy has heart failure. He's very clearly has congestive heart failure from his S3, which is something you see in CHF, and of course his hypertension. Blood backs up to the lungs, causing crackles and lowering oxygen saturation. Very straightforward. Egophony is an increased resonance of voice sounds heard when auscultating the lungs, often caused by lung consolidation and fibrosis. When something solid is there, you get the egophony aspect of things. Whispered paterlique is something you hear in people who have what are they? Well, this is kind of describing how you see it, but you can see what whispered paterlique usually in patients again with some kind of consolidation or liquid as well, right? We're kind of liquid release, even gaseous release, but something like that would have to be wrong. And in this question, they didn't give you any reason to think he has some kind of pulmonary pathology, right? So now in my respiratory video, which I haven't done yet, the new one I haven't done, but the old ones are still there. You do get to kind of see how to memorize all the different, let me show it to you guys real quick. Oh, right here. All the different lung sounds that you're supposed to kind of know very well, right? Tactile fremitus and percussion being the main ones, right? Egophony and whispered paterlique, those guys are much less common, but main thing is, breath sounds are always going to end up being decreased in everything except consolidation. In consolidation, breath sounds increase. Tactile fremitus also increases, but percussion gets dull. Right, percussion is only up in one thing, in a pneumothorax, because percussion kind of only really works with excessive air, right? In pleural effusion, consolidation, and lack of alveoli, you don't have excessive air. You don't have enough air at all, actually. So percussion doesn't work. Percussion is louder when there's a lot of air in a pneumothorax. Tactile fremitus is tactile. You have to knock on something like wood. So tactile fremitus is going to be seen in consolidation, increased in consolidation. Right? So if they give it to you that is decreased, all that really tells you is that it's not consolidation, but it could be any one of these other three guys. Okay? So these two guys are used more commonly than anything else to kind of really figure out what's wrong in a patient's lungs. Okay, this is a really nice question too, because it kind of takes to home a medication you do need to know very well, and it also tests you on a very simple concept about migraines. 30 minutes after taking 2 aspirin tablets for a tension headache, a 17-year-old girl has difficulty breathing. An adverse reaction to the aspirin is suspected. In the future, she should take which of the following drugs to treat her headaches? So, this patient has NERD, NSAID exacerbated respiratory disease, which is also referred to as aspirin-intolerant asthma. Many people can get aspirin-induced asthma. It's a very common thing that can occur. Taking an NSAID kind of prevents the production of all the COX products, so all your extra arachidonic acid gets shunted over to the 5-lipoxygenase pathway, and you make excessive leukotrienes. And all the leukotrienes generally increase bronchial tone, except for leukotriene B4, that one's for neutrophil chemotaxis. Acetaminophen is an NSAID also, but it works mostly centrally. So it's safe here in such a patient with NSAID-exacerbated respiratory disease, and it's also safe in patients with peptic ulcer disease, because again, it only really has effects centrally. Now, why was sumatriptan wrong? Because a lot of people wanted to pick this, right? You look at acetaminophen, ibuprofen, ketorolac, naproxen, and you're like, those are all NSAIDs, and you cancel them all out, and you pick sumatriptan and move on. But sumatriptan doesn't actually help with tension headaches. Okay, so let's take a look at everything. So page 528 for this arachidonic pathway. Right, so right here, if you give somebody any kind of NSAID, generally speaking, you basically cross out this entire thing, right? So now all this arachidonic acid goes in this direction, and that's going to cause excessive amounts of leukotrienes, which increases bronchial tone, right? And that's exactly how NSAID-induced asthma works. And that's what happened to our patient when she took 2 aspirins. However, and acetaminophen is the first one they talk about, acetaminophen only mostly works in the CNS because it is inactivated peripherally. They don't go into more depth telling you how that's cool and how that's effective and useful. But the cool thing about it is that you can use it in patients with peptic ulcer disease as well as patients with NERD. Let me put that here too. Right, because that's something that's very testable, and this is exactly how they would test it too. On step 1 too, like they would list it out with a bunch of other NSAIDs ever so nicely, and then you're going to pair them all up together. But acetaminophen is actually an ACE, and you should remember like that, like an ACE card, like a trump card. It's an ACE. It's different from all the other NSAIDs. Okay, and then of course the overdose stuff is another stuff that you can get questions on, and you treat it with N-acetylcysteine by regenerating glutathione. So that's just another off-topic thing to keep in mind for acetaminophen. Now let's take a look at sumatriptan, right? Why doesn't that work here? So 562 is where they talk about headaches. And if you look at it, right, cluster and migraine headaches, right, which are both unilateral, this stuff you can actually take NSAIDs for, right? What am I talking about? Hold on. Yeah, sorry, not that. Wait a minute. Our guy had a tension headache. Excuse me. Tension headache, right? You could take NSAIDs for it, and you could take NSAIDs for migraine. Excuse me. Right, so migraine and tension headaches, you can see NSAIDs are an answer choice. The sumatriptan is only for cluster headaches, and our patient did not have a cluster headache, right? So here you can see there's no sumatriptan. You do not use sumatriptan to treat a tension headache. So if you need to use sumatriptan, it's got to be for a cluster headache. That's the only place where sumatriptan, and of course 100% oxygen, can be helpful, right? And our patient didn't have that. Cluster headaches are usually men, and they describe it literally as pain behind the eye, right? And it can actually present with lacrimation, rhinorrhea. The pain is really, really bothersome, and these patients almost always come in because it's very debilitating to have that kind of headache. Migraines are very common, usually very chronic, long-term stuff, and eventually they end up coming. The cool thing and the unique thing about migraines was the aura part. Right? Oftentimes they kind of know it's coming. They're often worried about the migraine coming too. And they're always going to be like, man, I don't want to travel right now because I'm going to hate having migraines. It's something that they're always worried about. Very much like people who have panic disorder are worried about their panic disorder. So migraine people are often worried about the migraine that they're going to get. And you can give them NSAIDs, triptans, dihydroergotamine, a bunch of other stuff. Mostly the prophylactic stuff is what people use, and lifestyle changes are very, very important. That's the first thing you recommend. But tension headaches, you cannot use sumatriptan. No triptan usage here. All right, so always remember that. Tension headache, no triptans. Triptans will not help here. And for cluster headaches, no NSAIDs. You can't use NSAIDs for cluster headaches. All right, so if you thought this page was a really easy one to get, yeah, sure it was, but you got to make sure you got to get the treatment aspect down very accurately, right? Because that's exactly what this question is picking on. Right? This question is picking on two different things. Understanding acetaminophen is central, and understanding that sumatriptan does not help with tension headaches. Right? Sumatriptan is for the other two guys. You could use it. It's the only thing you can really use for cluster headaches, and it's one of the things you could try for migraine headaches. But people don't really tend to take sumatriptan, long term. It's not exactly very easy to take, and then of course it can have cardiac side effects for some people too. So someone taking a sumatriptan might end up presenting with angina, and they would have to stop taking it due to coronary vasospasm, right? So not exactly the safest medication, but very important to remember that stuff. Always remember, triptans do not help with the tension, and NSAIDs do not help with cluster. 38-year-old man is admitted to the hospital after sustaining multiple injuries in a farm implement accident. The day after admission, his plasma fibrinogen concentration is increased. Which of the following is the most likely cause of this finding? So they didn't tell you that something's wrong here, though, right? There's nothing wrong here. They haven't given you some kind of pathological issue. Of course, he had an accident. That occurred. But it seems like he's probably going to deal with it just fine. Having high fibrinogen the day after the admission, or the day after the incident, is very normal. You need fibrinogen. Remember what fibrinogen did? It used GP2B3A to connect platelets. Right? It's the thing in between. To connect multiple platelets is part of the aggregations part of dealing with bleeding. So there was no reason to pick anaphylaxis. DIC would have more fibrin degradation products, the D-dimers, but not more fibrinogen. Hemoconcentration was just a weird answer choice to, kind of make you pick it if you were really lost. Hemoconcentration is a decrease in plasma volume, right? Which is really easy to understand, right? So heme concentration, high amounts of heme, low amounts of plasma volume. And that can cause simultaneous increase in the concentration of red blood cells and other commonly tested constituents of blood. But that's not what this patient's stuff is. There's no reason for this patient to just lose plasma. He probably lost some blood too, because he sustained multiple injuries. Histamine triple response is just another bullshit answer choice. This is a real thing. You should Google it and learn it too, but it was irrelevant here. Acute phase reactants are upregulated during the systemic manifestations. More fish in the sea for ferritin, fibrinogen, serum amyloid A, hepcidin, and C-reactive protein. Fibrinogen was the thing for our question. This was just a straight up question from the cardiovascular farm about these medications, right? The lipid-lowering agents. So nicotinic acid acts at which of the following labeled sites in the diagram of lipid metabolism? And you should know all the parts for the most. Some of these parts might not be real. So nicotinic acid, same thing as niacin or vitamin B3, all different things, all different names for the same thing. Its job is to reduce hepatic VLDL synthesis. It also inhibits lipolysis by stopping hormone-sensitive lipase, which works in cases of stress, hormone-sensitive lipase. Niacin may cause hyperglycemia or hyperuricemia, and it can cause flushing, which can be prevented with aspirin. All right? So here the answer was just C. It stops hepatic VLDL synthesis, thereby lowering blood cholesterol. A, where's A? Excuse me. A right here from the gut to the hepatocyte, right? So absorbing bile acids from the gut is if you're taking something that stops A from happening, that's going to be a bile acid resin. And I always remember bile acid resin as let the bile reside in the gut, right? So that's the simple part there. B is also the easiest one. You should always remember HMG-CoA reductase inhibitor right here. So statins, right? Not exactly sure what the D one is. VLDL becoming IDL. I'm not sure what would stop that. And then E, remember the PCSK9 inhibitors, which cause LDL removal from the bloodstream, right? So that's kind of what they're showing here. VLDL being removed from the bloodstream, right? Again, this might be PCSK9 inhibitors. I'm not 100% sure. But either way, whatever's happening, it was easy to figure out that the answer choice for our question is C, right? The bile resin, the cholesterol becoming VLDL, right? That part. That's exactly what niacin does. So let's take a look at it in the book real quick. So right here, niacin, vitamin B3, you can see it has a couple nice a couple nice effects. And in the book, they tell you directly, right? Reduces hepatic VLDL synthesis, right here. And then when they have the visual aspect, this is kind of the diagram they're using in our question too. You can see, let's see. So PCSK9 thingy is right here, so that's a little different. And our thing is, where's niacin? Where they put it? Yeah, right here, niacin, right? Adipose lipolysis. Adipose tissue, free fatty acids, that's one part of it that they're showing you in this diagram. They're not showing you in this diagram the VLDL synthesis that's being inhibited, but that's what our question tested you on. Right, so this thing where they're showing you here is the activity of the stress-related hormone-sensitive lipase. Right, hormone-sensitive reminds you of the hormone cortisol, right, stress-related, and this is lipolysis you see in someone who might be like starving due to some kind of big mission they're on or something like that, or hiking, or someone that might have fallen in the kitchen and can't move anymore and they, don't get to eat for like 30 hours or something. They would do a hormone-sensitive lipolysis with hormone-sensitive lipase, HSL. So niacin inhibits that as well. That's another thing you can get a question on. 31-year-old woman in the second trimester of pregnancy is brought to the emergency department because of vaginal bleeding. Blood pressure is high. Ultrasound shows a conceptus with patches of tissue containing vesicular structures but no apparent embryo. The tissue is surgically removed and genetic analysis shows a 69XXY karyotype. So it was basically a molar pregnancy in a sense, right? The presence of which of the following would indicate that an embryo had been formed within this conceptus. Right? And then they give you all these answer choices, which are pretty much all related to pregnancy, all related to, a pregnant woman, and embryology. And then you're just like, which one of these doesn't tell me about actual conception? So the cytotrophoblast, primary stem villus, syncytial trophoblast, and any trophoblastic tissue whatsoever, those are all part of the developing placenta, right? And the placenta's job is just to supply the fetus in utero, take nutrients and oxygen from the mom, give it to the developing fetus. These structures are all derived from the trophoblast, which is considered extra-embryonic tissue. Hematopoietic stem cells, the correct answer, is the only answer choice that would indicate fetal parts were formed. Okay, and if we don't see hematopoietic stem cells, no fetal parts were formed. Right, and 69XXY, that's just, if you don't remember your molar pregnancies, then this isn't a direct question about molar pregnancies, but if it were, you should know it, so definitely make sure you revise that as well after this video. This was a silly question. It was more so testing you on like your understanding of viruses rather than knowing each of the viruses by nature. So a new virus has been isolated that causes encephalitis, right? So this is very experimental. The viral particle contains RNA-dependent DNA polymerase. Which of the following types of RNA is most likely to be the genome of this virus? Okay, so it's just a fantasy question. It's just fake. I'm not sure what virus they are discussing because it is new, so it's not about a real virus. This question isn't about a virus that's in your book or something. But you should know the general basics to be able to pick the answer, because they told you that this virus has RNA-dependent DNA polymerase. All RNA viruses are single-stranded, except for repeatovirus, or what is actually called as reovirus. And reovirus is a linear double-stranded RNA virus, which is neither positive or negative sense, so cancel B. Right? It has to be positive sense RNA virus for you to use RNA-dependent DNA polymerase. So if you just remembered that much, you would be able to pick D, because that's the only guy who can actually use it, right? Because after you cancel all the double-stranded guys, you're down to single-stranded guys. And between negative versus positive, you have to remember positive is great. You have to be a positive RNA virus. Positive RNA viruses are use RNA-dependent DNA polymerase to replicate themselves. And the same positive RNA can also act as a messenger RNA to make more proteins and cause virulence and cause disease and whatever. Okay, so these things are discussed in first aid. They are in the microbiology viral section. So make sure you understand this basic concept of how viruses work, because this is a big part of step 1 as well. Hypertension. Okay, so 53-year-old woman with a long history of fibromuscular dysplasia involving the left renal artery develops hypertension. Her left kidney is smaller than normal, right? You don't even have to say the numbers. Just understand it's smaller than normal. She's being evaluated for a revascularization procedure. A left kidney biopsy is performed. Which of the following histologic findings is most likely? Deposition of fibrinoid, diffuse infiltrative neutrophils, mesangial hypercellularity, atherosclerosis and arteriosclerosis, tubular atrophy. We just said it, right? That the left kidney is smaller than normal and atrophy is getting smaller than normal, so it would just be that. There's nothing actually wrong intrinsically with the kidney, so you're not going to pick any of those other answer choices, right? There's nothing wrong with the kidney itself. The patient has fibromuscular dysplasia, which is basically a renal vascular disease. So you're not bringing enough blood into the kidney, and without enough blood, you get tubular atrophy, which is a general term that describes several patterns of chronic tubular injury with thickened tubular basement membranes and much more stuff. Okay, so make sure you understand that proteinuria is variable depending on the cause. And when you have tubular atrophy, you can get proteinuria. Right? But again, not a very crazy question. You don't want to think too hard. Understand that in fibromuscular dysplasia, the kidney is fine. It's not the kidney that's bad, it's the vessel going to the kidney. This was a unique question. I actually got this wrong. I had never heard of this before. So 76-year-old man with a 1-month history of pulsatile abdominal mass is diagnosed with an abdominal aortic aneurysm. Then they shift gears all of a sudden from cardiac to renal. CT scan of the abdomen with contrast also showed an incidental finding of a horseshoe kidney. In this setting, the surgical approach to repair of the aneurysm in this patient is most likely to be further complicated by the presence of which of the following, right? So what's going to complicate their surgical approach? So I knew it's not A. Nothing happened to the SMA. So you can cancel out A, abnormal origin of the supreme mesenteric artery. Why would the supreme mesenteric artery have an abnormal origin? It won't. Anomalous origins of multiple renal arteries to each kidney. Never heard of that. Didn't think this was real. Canceled out B, but that was actually the correct answer. C, friability of vascular tissue as a result of collagen synthesis abnormalities. I don't know of any collagen synthesis abnormalities related to horseshoe kidney. It's really just the kidney didn't separate. The bottom poles are, linked together. So I didn't think it was C. Multiple ureters with abnormal courses. No, there's only going to be one ureter coming from each kidney. There's nothing wrong with that stuff either, so I didn't pick D. Then I saw E, tumors with malignant degeneration. And I thought, okay, sure, this organ is in a place where it's not supposed to be, and maybe something's going to be wrong with this patient because, he has a pulsatile abdominal mass, which I assume means he smokes. He's probably a white guy who smokes. So based off of that, I was like, I'm going to go with E because I really never heard of B, but B was the correct answer. So the inferior poles fuse and the kidney gets stuck under the IMA, right, under the inferior mesenteric artery. And now it's not going to rise up to the level of the SMA, which is where it's supposed to go up to. You may actually note accessory renal arteries from the aorta to the kidney, and they can look like any one of these pictures. Okay, so when they try to fix his aneurysm, these extra arteries coming off of the aorta are what's going to complicate the surgery. So you see how this is something that's not in first aid. They don't even mention it. There's not even a whisper of this in first aid. So it's good to, I guess, you're not really supposed to learn from NBME per se. NBME is a test you pay for to actually pass and get permission to take step 1. But if you have to learn, you have to learn. Right? So they didn't mention it here at all. I just wrote this right now. Right? Patients often have anomalous accessory renal arteries from the aorta. Do need to know that. This was an easy question. 73-year-old woman dies 7 years after the onset of progressive memory loss and depression, which you would assume is Alzheimer's. She had severe intellectual deterioration at the time of death. A coronal section of the brain at autopsy is shown. Histologic sections showed numerous neuritic plaques in the cerebral cortex and numerous neurofibrillary tangles in the cortical neurons. And this is a sentence that NBME usually doesn't give, but it's nice that they gave it because that kind of mimics, step 1 design a little more. And those things, the neurofibrillary tangles, neuritic plaques, those are all more confirmatory giveaways for Alzheimer's. Which of the following is the most likely cause of the ventricular enlargement? So all you're really supposed to remember when you think of this one is that this patient doesn't really have ventricular enlargement. It's that the rest of the brain disappeared, right? So this is actually hydrocephalus ex vacuo, right? The 4 types of hydrocephalus are communicating, non-communicating, ex vacuo, and normal pressure. Diagnosis is typically made by physical exam and medical imaging. And it's very important to make sure you know the differences between them because, again, this is also a topic that's not so hard, right? Communicating means that there's no blockade. So if you have hydrocephalus, right, communicating means that the flow through all different parts are going just fine. So all CSF flow routes are fine, but CSF is either not being absorbed or you're making too much of it. So communicating hydrocephalus is a lack of absorption, right, by the arachnoid granulations, which can occur post-meningitis. Normal pressure hydrocephalus, NPH, occurs in the old people, really elderly. So I just think of them as they're too old to be able to absorb it correctly. Right? So since they're not absorbing their CSF, it leads to urinary incontinence, gait apraxia, and cognitive dysfunction. Wet, wobbly, and wacky. Right? Normal pressure hydrocephalus. Really like a very iconic question type. There's a couple of practice questions out here that talk to you about both things. Right? So this one's hydrocephalus ex vacuo. The second one here is normal pressure hydrocephalus. You can pause the video and check it out whenever you want. Non-communicating means that something's blocking it, right? Obstructive. Something is impeding CSF flow. And that's usually going to be some kind of tumor, or something, stenosis of the aqueduct sylvius. I've never really seen that, but usually a tumor will cause non-communicating hydrocephalus. And then ex vacuo is because of brain degeneration, right? It's not that you have ventriculomegaly, but rather than the brain around the ventricle is kind of disintegrated. So now your ventricles look bigger. And that's usually seen in Alzheimer, HIV, Pick, Huntington, right? Intracranial pressure is normal. And the NPH triad is not seen. Okay, this one I got right, but only because I've been kind of preparing to do the respiratory videos lately. But I don't know if I would remember this. Well, I do remember the equation, so I guess that would be enough to get it right. But I didn't actually remember the equation. I didn't think of the equation when I was doing the question. But when I was writing out the explanation, I looked at compliance. I was like, oh, yeah, that equation. But how do you solve this? So a 24-year-old man who is comatose is admitted to the hospital because of a drug overdose and pneumonia. On admission, he is intubated and mechanically ventilated. While receiving a tidal volume of 500 milliliters, the patient's end expiratory pressure is plus 5 centimeters H2O. Right? So when he breathes out, at the end of expiration, his pressure is plus 5. And his end inspiratory airway pressure is plus 25. So when he completely breathes in and he's done breathing in, it's 25. Right? So there's an amount of space in between, right? The pressure difference is 20. An esophageal balloon is inserted and an end inspiratory pleural pressure of plus 20 is also measured, which is a different 20. Which of the following best represents this patient's respiratory system compliance? So compliance is actually mathematically a thing between pressure and volume, right? When you're talking about something like a lung, any kind of balloon, right? Compliance has to do with how much volume can you put into here and still have it, sustain pressure so that it doesn't burst, right? And mathematically, it's like this: delta V over delta P, which is just 500 divided by 20, right? And yeah, right, and then you get 25, and that's the answer here, E. Okay. So again, you don't necessarily have to worry too much about this equation. It's pretty easy to remember, and if you've looked at this question with me just now, you probably won't forget it, right? So it's not that difficult of an equation to work with. The other answer choices are really all just there for, I don't know what kind of mistakes people can make, but they definitely have an answer choice for every kind of mistake, because these ones, A, B, and C, are probably for something the other way around, like 20 divided by 500, and then you would get one of these answer choices. So you got to be careful. If you flip this around, that's actually elasticity, right, or elastance. So elastance is delta P over delta V, which is basically telling you how elastic is your lung, how much volume can I actually fill it up with, right? And it's a very mathematical and physics type of concept there. So don't worry about it too much. Just make sure you remember delta V over delta P for compliance. That's definitely medically relevant. Okay, so a 4-pound male newborn, and 4 pounds is pretty small. A 4-pound male newborn is delivered in the hospital at 39 weeks gestation to a 40-year-old woman, G4P4, via an uncomplicated vaginal delivery. Shortly after delivery, he develops respiratory distress and dies 8 hours later. Right? It's a very small newborn, so definitely some kind of development issue there. At autopsy, examination of the pancreas shows congenital absence of the pancreatic islets. The most likely cause of this congenital abnormality is a defect in the initial differentiation of islet cells from which of the following precursor cells. And then they put neurocrest cells as an answer choice, and that's always going to be an answer choice to any embryology question you ever get. And on top of that, they didn't just say, oh, the pancreas is missing or there's something wrong with the pancreas. They specifically picked islet cells of the pancreas, so that if you were kind of weak on remembering neurocrest cell derivatives, you might think, yeah, those islet cells came from neurocrest cells, and you pick it. But this was just a question about the pancreas embryology, and the pancreas comes from endoderm. So if there's something wrong with the pancreas, you've probably never studied anything about those alpha, beta, and delta cells of the pancreas coming from neurocrest cells, or from anywhere special, really. So it's not neurocrest cells. This is just endodermal cells, and you just pick that, and that's it, right? Really important to make sure you spend routine amounts of time are looking at the embryologic derivatives, which means that you come back and look at it at least once a week. Just come back and look at it, and not come back and look at it only, but if you have questions about any of the neurocrest cells derivatives, come back to this page. And anytime you're doing a question about any one of these things, right, any one of these things on these two sections, meso and endo, stop and think to yourself, yeah, that's mesodermal, that's endodermal, that's mesodermal, and get used to having a good understanding of where this embryology is from. What does mesoderm give you? What does endoderm give you? Start thinking about the embryological aspect of every single organ, because maybe in the beginning you weren't thinking about it, and this is kind of why I recommend everyone to do step 1 prep from the same order it's all listed out here. Even though this is ABC order, cardiovascular, all of that, it helps, because by the time you get to repro, you should be really good at all the other organs, and then now you can start thinking of the embryological aspect of the organs. Okay. And Vactorel is definitely another thing you can get questions on. So this is actually an example of that from Amboss, and I've seen another one from UWorld too. Okay, so again, the receptor stuff. So 36-year-old woman comes to a physician because of a 4-month history of chronic fatigue. Physical exam shows a macular rash over the face. Serum studies show presence of antibodies. Urinalysis shows proteinuria. And it's kind of all looks like lupus, and it is, right? Biopsy specimen of the renal tissue gives you lupus nephritis. Treatment with prednisone has begun. This drug acts by binding to its receptor in which of the following sites? Right, so prednisone is a corticosteroid, which makes it a steroid hormone. As a steroid hormone, it's definitely going to have something to do inside the nucleus. So that really just cuts it down to A or D, right? And whether or not you remember is the only other way you can pick between A or D. Is it cytosol with translocation into the nucleus, or is it outer nuclear membrane with translocation into the inner nuclear membrane, right? And let's go take a look at it. So 358. So this time the question was actually about this stuff, right? Signaling pathways of steroid hormones. You can see how the steroid hormone comes in, it binds a receptor in the cytoplasm, right, and causes transformation of the receptor to expose DNA binding proteins. This thing then gets translocated in to bind DNA. Right, so that makes the answer A. Cytosol with translocation into the nucleus. Right, outer nuclear membrane with translocation to the inner nuclear membrane. Not exactly sure what that one would be. Outer nuclear membrane. Yeah, I can't think of something that would use the outer nuclear membrane, which is this one, and then go into it. So that's, I'm not sure what that question would be, to be honest. Here, okay, this was a little fucked up. 10-year-old boy has bruised easily since swallowing some of his grandfather's pills 2 days ago. Aspirin and dicumarol are found in the medicine cabinet. Which of the following lab's findings would suggest that he took dicumarol rather than aspirin? To me, more importantly, I kind of want to meet this old man, right, and the grandfather, and I want to, find out who his doctor is, because who prescribes dicumarol? No one takes dicumarol. And no one should, if any of you who did this question knew what dicumarol is, that's crazy, because that's not something an average human should know. And so you can basically think of dicumarol as warfarin. Its mechanism of action is actually to deplete vitamin K storages, which sounds really stupid to do. But since vitamin K is involved in gamma carboxylation of factors 2, 7, 9, and 10, you can use PT to measure the response. But you would never really give this medication. You would rather give warfarin after doing a heparin bridging. Warfarin actually stops you from using vitamin K to make coagulation factors. If you deplete vitamin K storages, you're just getting rid of vitamin K in general, and it is essential. You need vitamin K. So the answer here was just E, prolonged prothrombin time. Right, prothrombin time, PTT. PTT measures the extrinsic pathway of coagulation, which is mainly mediated by factors 7. And warfarin stops 2, 7, 9, and 10. 7 is special. It's extrinsic. It's unique out there. If you do not know what dicumarol is, like any other normal human, then you get to use logic, right? So now you have to tackle this question logically. A and C. A says decreased plasma fibrinogen concentration. C says decreased platelet count. Those two things, if either one was true, would not prove that aspirin was not used, right? Because aspirin does affect platelets. And we're trying to figure out, our question says, what suggests that he took dicumarol and not aspirin, right? So decreased platelet counts, again, you could see that with aspirin. So, not going to be really significant. Decreased plasma fibrinogen concentration. Fibrinogen concentration will go down if all the fibrinogen is getting used up. And again, that's not relevant here either. Answer choice B is a very unreal answer. Decreased partial thromboplastin time, PTT. Partial thromboplastin time should not decrease. Nothing decreases it. These times, PT and PTT, they get increased, not decreased, right? So B is a very unrealistic answer. Answer choice D seems very, very appealing. Normal clotting time. Okay, we're trying to prove this guy took dicumarol. Dicumarol, if you took dicumarol and you have normal clotting time, that means that dicumarol didn't do anything to clotting time, but we still didn't prove what did dicumarol do. How am I supposed to prove what dicumarol did if I just found something normal? So you cancel out D also, and you're just left with one sensible answer choice, prolonged PT, prolonged prothrombin time, and that's the answer here, right? Because dicumarol would prolong your prothrombin time, PTT. A prolonged PTT does not occur with aspirin at all, for sure. So you can also pick that for another reason. Aspirin would have no effect on your PTT or even PT for that matter, right? So two different ways to answer this. Either you somehow mysteriously know what dicumarol is, which now we can all know after this question, or you do a logical breakdown. Again, logical breakdowns though are very difficult to do, especially if this really is question 193 out of 200 for you, because by now you're pretty worn out. Another question about lipid-lowering agents, but this is the typical easy one. So this question literally just said that the patient has symptoms of myopathy, right? They straight up tell you that muscle aches and brown urine, which is myoglobinuria. They tell you that he's taking simvastatin. What other medication would be bad to take? That would just be gemfibrozil. Combining fibrates and statins increases the likelihood of adverse side effects of myopathy, and that's a definite no-no. This can also occur with niacin and ezetimibe as well, but the most important no-go combo is a statin and a fibrate. Okay, so there's no reason for you to pick anything else. This was just a psychology question. It's a 38-year-old single woman with a history of chronic headaches comes to the physician for a follow-up exam. She has 3 sons with sickle cell disease for which they have required frequent hospitalizations. She tells the physician that she used to feel angry and abandoned by her family as they have provided little to no support in helping her with her sons. She states that she recently started taking kickboxing lessons and now she feels happier and more relaxed. She adds that her headaches have also improved. This patient is most likely using which of the following types of coping mechanisms? And the only answer you could pick is displacement. Now, realistically, the way she handled her anger is very mature and acceptable. So sublimation would be a better answer choice here. Sublimation would be the answer choice you should actually go with. But that's not one of your answer choices, so you don't really pick sublimation. And now you can see all your other answer choices. And displacement. Displacement is the only answer choice worth picking here. So she is redirecting her anger towards a neutral bag, the one that she's kicking. And by doing so, she's indirectly kicking her family. So, this is the difference between mature versus immature. And what the question is kind of teaching you is the way she handled is immature. I don't see how that's immature. She has anger. She's taking it out in, kickboxing. But either way, that's the correct answer here. Now, projection is something you're supposed to compare with displacement. But projection, in projection, instead of redirecting your anger, you make it look like someone else is angry at you. So in the book they tell you that a patient a husband that wants to cheat on his wife keeps questioning his wife if she's cheating on him. That kind of thing is projection. So you give your image onto someone else, right? So I'm angry. Now I'm going to make someone else say, oh man, why are you angry at me? What's wrong with you? That's what they're doing. So the word projection fits perfectly. You're projecting yourself onto someone else. Definitely wasn't rationalization. Definitely wasn't suppression. Neither of those things. Reaction formation is another plausible answer choice someone can pick. That's an equal but opposite reaction. Remember from Newton's laws, reaction formation, equal but opposite reaction. Every action has an equal but opposite reaction. And that helps you remember that an angry person would go display joy. You do the opposite of how you actually feel. Right? So that's what reaction formation is about. But here the answer was just A, displacement. This was a question about vaccination. So, parenterally administered cholera vaccines consisting of killed whole bacterial cells have very limited efficacy. Which of the following is the primary reason for this failure? All right, so now, when you read this question, you might get very intimidated, especially if you haven't looked at vaccines in a while. You don't really know the whole conceptual aspect of different kinds of vaccinations. What they're talking about here, though, first things, just think about it. Parenterally versus what? Right? So versus oral. Right? That's what they're talking about. Giving it IV rather than taking an oral vaccine. That's the comparison they're making. The question asks about parenteral administration of the vaccine, meaning not using the oral route. Non-oral vaccines will not strongly elicit an IgA response. Remember, secretory IgA is lining your gut lumen. It's very helpful. Non-oral vaccines, not super helpful in combating a gut mucosal infection such as Vibrio cholerae, where IgA is more salient. Right? If it was anything else, it'd be different. But cholera, is a problem with the gut. Not sure if this is the actual correct reasoning, but it led to the right answer. Which, and generally speaking, it is kind of the right reasoning here. So the answer was just C. Inability of the vaccine to elicit secretory antibody at the epithelial surface, because it will never actually make connection to the IgA. You took it IV. All right. Chlamydia, 17-year-old primigravid woman at 16 weeks gestation has a mucopurulent vaginal discharge. Culture of the discharge shows chlamydia trachomatis, which of the following is the most appropriate pharmacotherapy. And they were nice to you here. They didn't put doxycycline as answer choice A. But the most important thing to note here is that the patient in the stem is pregnant. The question wants to see if you know that doxy is a teratogen. Tetracyclines, like doxycycline, in general, like to bind to fetal bone and teeth, which can impair development and cause discoloration, the yellow discoloration. So the correct answer here was to pick azithromycin. Both tetracyclines and macrolides, as you can see from the sketchy micro image, tetracycline and all cyclines are always depicted by a wheel, and macrolides are crows. Okay, the three flags here are to also tell you about what was the three flag thing? Ceftriaxone, right? Ceftriaxone. That's another answer choice you could pick, but they didn't have that here. It's a tri-axis ceftriaxone. But macrolides, again, safe to give to a pregnant woman. Azithromycin would just be the answer here. This one, so we're almost done. 2 more questions after this. 6-month-old boy has recently been diagnosed with developmental delay. He has had difficulty feeding and recurrent vomiting since early infancy. He was found to have hepatosplenomegaly and lymphadenopathy during a routine exam at 3 months age. So hepatosplenomegaly, lymphadenopathy, developmental delay, vomiting. Examination shows bone marrow with numerous foam cells, and that kind of gives away the diagnosis. A defect in which of the following metabolic pathways is the most likely cause of this disorder? So this is straight up describing Niemann-Pick disease, right? Only Niemann-Pick and Tay-Sachs have a cherry red spot, which they really didn't talk about. On the macula. And Tay-Sachs has no hepatosplenomegaly. They didn't really give Tay-Sachs as an answer choice anyway. You could tell most of these other answer choices are actually from the dyslipidemias. Niemann-Pick disease presents with mental retardation, lipid-laden foam cells in the bone marrow, and a cherry red spot on the macula. And that's what this patient is presenting with. No sphingomyelinase results in a buildup of sphingomyelin, which builds up in macrophages. All right. So very straightforward. Once you see this answer choice, it should ring a bell. You check the question again, and you pick D. This was a congenital adrenal hyperplasia, which is best memorized using this. Okay, so during the first week of life, a male newborn has vomiting, severe dehydration, hyponatremia, and salt wasting. Serum 17 hydroxyprogesterone concentration is increased. The most likely cause of this disorder is a defect in which of the following enzymes, right? And what is this? Yes, C. So, of course, it was just 21 hydroxylase. And how do you get this down? How do you memorize all your congenital adrenal hyperplasias? She does this all night too. This is when I say my cat is on her period. This is just she's on her period. Can't do anything about it. So the numbers, right? 17, 21, and 11. This is how you kind of memorize it. The one pointing up is an arrow pointing up. And let's actually look at this in the book to get this down a little better. So you don't need to worry too much about this diagram. Of course, spend some time, learn it. Make sure you look at aromatase and file for reductase 2. Those are also significant. Mainly the green and red things that are upregulating or downregulating stuff. So ACTH, obviously very important to start things. Angiotensin 2 here for just the aldosterone synthesis. Now this is where you need to memorize stuff, right? So we're looking at mineralocorticoids, cortisol, and sex hormones, okay? And these are the up and down arrows I'm talking to you about when I'm talking about these numbers. So the first one is up. That means mineralocorticoids are up, right? In 17, only mineralocorticoids are up. Cortisol is never up, so don't worry about it. It's either the first digit or the second digit, which means mineralocorticoid or sex hormone. In all of these, cortisol is low. So if in 17, the first digit is up, that means mineralocorticoids are up. That is going to cause you to have no sex hormones, right? Because obviously if this is the only thing that's up, that means this is low. If you have low testosterone, then the male, is going to have ambiguous genitalia, and the female is going to lack secondary sexual characteristics. In 21, you have excess androgens, right? But you don't have, of course, mineralocorticoids. So you're going to have salt wasting. You're going to have salt wasting, and the excess androgens don't really do anything to the man, per se, but females get virilized. Too much testosterone, okay? And then again in 11, both things are high. So you have high aldosterone and you have high sex hormones. So again, the female gets virilized. The excess testosterone doesn't really do anything to the man. But high aldosterone will cause hypertension, right? Just like it did in 17. High aldosterone will cause hypertension, right? The main difference between 17 and 11 is that here it's actually 11-deoxycorticosterone, not actual aldosterone that's causing this. So renin activity is actually low, right, as opposed to 21, right? Renin activity is high here, right? And it's high here because you don't have any aldosterone, but here renin activity is low. It's very important to remember that. Right? You have this fake aldosterone. It's not actual aldosterone. It's a cortical intermediate that acts like aldosterone. So it's a very easy way to just utilize the numbers themselves, 17, 21, and 11, to help you memorize mineral, cortisol, and sex hormone, what's up and what's down. And in our patient, they gave us salt wasting, right? Hyponatremia. So if you have salt wasting, you're not making aldosterone, and that it cannot be B or D, because you see the first one is up here, the first one is up here. So both in B and D, in 17 and in 11, you make aldosterone. So why would you have salt wasting? So the only way you can have salt wasting is 21, where you have excess androgen. It's not going to cause any physical symptoms in the male, but if this was a female newborn, that would be ambiguous genitalia. Right, so once you learn how to, intelligently handle figuring out congenital adrenal hyperplasias using the numeral memorization method, it's a joke after that. There's nothing confusing about it. I know initially it was very intimidating. And then our last question, something that you obviously definitely need to know inside out super well, are your portosystemic anastomoses, because GIT is all about the GIT anatomy, right? That's 50% of GIT. The rest of it is about the polyps and colon cancer and all the different absorption issues and whatnot. So here they tell you, 52-year-old man with a history of alcoholic cirrhosis is brought to the office by his wife because of a 4-hour history of rectal bleeding. So 4-hour history of rectal bleeding, okay? Alcoholic cirrhosis. So you immediately know this is going to be a question about portosystemic anastomoses. He has a history of alcohol use disorder, he's an alcoholic, and he also has hemorrhoids. Pulse is 100, blood pressure is okay, physical exam shows pallor because of the anemia. Varicosities in this patient are most likely located in direct tributaries of which of the following veins? And they give you a bunch of answer choices, at which point you're kind of stuck between inferior rectal and superior rectal. Remember that, and first of all, always remember it's veins, so they already put that, these are all veins. Remember that the superior rectal vein, remember that portal, your liver is up here. So the liver is going downwards, and if you have rectal bleeding, it must be the superior rectal vein coming downwards that's causing the bleeding. Inferior rectal vein comes up from below, and that's not the one that's causing the portosystemic anastomoses, right? So let's take a look at that well, this image here does the job for you for the most part. This is your hepatic portal vein. If you have too much pressure here, stuff backs up, right? It's going to go here and show stuff in the umbilical area. It's going to go here, go back to the spleen, right? Cause issues in the stomach. Go down your IMV, inferior mesenteric vein. Blood is backing up into the inferior mesenteric vein, backing up into here, and then you have your superior rectal vein, right? Backing up into here, and you end up bleeding rectally, rectal bleeding. So 396 shows you right here your actual portosystemic anastomoses, and you see how the anastomoses is between the superior rectal, which is the portal part, and the middle and inferior rectal, which is your systemic part. Right? But you have to remember the superior rectal part, which is this dark blue one. Right? That's your portal stuff. Middle and inferior rectal come off of inferior vena cava, which are systemic blood flow. Okay. Same thing here. Paraumbilical vein, right, coming off of this right here. Your paraumbilical vein is the one that causes the dilation of blood vessels here. Okay, and then the left gastric. Never forget, left gastric is the one that has some esophageal branches up here. Okay, left gastric vein. A left gastric vein is part of your portal system. Okay, so definitely need to remember this stuff because this gives you like very easy questions. All right. So that's it. That's the end of NBME 22. Thank you very much for following along. I really hope this helped. Very good NBME, worth doing, worth understanding, and keep revising all NBMEs, because when you do this breakdown of looking at NBME with UWorld type explanations from first aid and other resources, you start really mastering the topic, and then you become very good at it. So that's the end of that. Tomorrow I'll go back to continuing off first aid. Thank you very much for joining, and then I shall see you guys later on.